Thank you very much for the kind invitation and introduction. It's my immense pleasure to be here with you today. So it feels like for many, many years I've been a friend of the family of CIBM, and now I'm invited to sit at the table or so participate more actively as a section head. So my talk will be on brain networks and multimodality, focusing on application to epilepsy, and I'll show you what we can learn from it also for other brain functions. And I've taken the opportunity of this anniversary, 20 years of CIBM, but 100 years of EEG. So even though I feel a bit of an outlier talking to you about EEG, with all these very remarkable MRI talks and other research. So I'll do my best to convince that EEG also has its place as an imaging tool. So EEG, as I said, is 100 years. This is a picture of the initial recording setup from Hans Berger in Jena in Germany 100 years ago, where he recorded basically the alpha rhythm with two electrodes, so one active electrode recording the posterior cortex and one reference electrode in front of the ear. Of course, now things have moved on. We have now multi-channel EEGs. From these multi-channel EEGs, we can identify normal and pathological electrical transients. And we can do a lot of very sophisticated analysis. We can do time frequency analysis. We can do spatial analysis of voltage maps. We can go into source space, and we can analyze networks between different sources. So the plan of my talk will be to give you some illustrations of the current research and perspectives using EEG in brain imaging, and to show you this bidirectional, mutually beneficiary relationship between EEG and epilepsy. And of course, for all that, I will be very happy to continue the inspiration that was given to me by Christophe Michel, who was my mentor for EEG research, and from Margita Seik, who was my mentor for epilepsy research. So maybe for those of you who are less familiar with epilepsy, I'll start with a brief introduction to tell you that epileptic seizures are characterized by transient symptoms caused by excessive and synchronous activity in a neuronal population. So you can have seizures starting from one particular part of one hemisphere. These are focal seizures. You can have general seizures that engage from the start bilateral circuits between basal ganglia and cortex. And you can have focal seizures that recruit these bilateral networks and become secondary generalized. If you have an enduring predisposition to have recurrent seizures, then you have epilepsy as a disease and not just a symptom of epileptic seizures. This is a frequent, one of the most chronic brain disorders that affects close to 1% of the population. It can start at all ages. It has multiple causes, and therefore we don't have one epilepsy, but different epilepsies. Of those, a large majority is focal, and a third of the patients are not sufficiently controlled with medical therapy, so with drug, anti-epileptic or anti-seizure medication. For those patients who are not controlled by medication, we can try to see if we can localize an area that could be removed surgically to control their seizures, so to remove the epileptogenic zone. This pre-surgical evaluation is based on a multimodal and personalized workup, where the core investigation is to record long-term video EEG to record seizure, both in terms of semiology, so the clinical signs, and the EEG. And then we confront it to the detection or to the search for a lesion on the structural MRI, to search for metabolic or perfusion changes in nuclear medicine tests such as PET and SPECT, to some cognitive workup. And then in the end, a multidisciplinary team decides whether this is a good case for a surgical resection, whether the epileptogenic zone has been well localized or well estimated, or whether maybe an intermediate step with intracranial electrodes in the form of subdural grids or depth electrodes are needed. In well-selected candidates, so more than half, between half and 85% of the patients can be rendered seizure-free. Of course, this is a field where a lot of additional non-invasive tests are needed to enhance, to increase the quality and the accuracy of the workup. And this is, of course, also a field with the invasive electrophysiology and the post-surgical outcome where you can validate the localizing tools that you develop and test. So, you've heard a lot of talks of Christophe Michel and other EEG experts over the years, so you know that with high-density EEG, you can build voltage maps at every time point of the recording, and then you can look sophisticated inverse solution to look at the cortical sources, to estimate the cortical sources related to these maps. These sources, you look at the source with the maximal power as a surrogate of epileptic activity, so the maximum power related to interictal epileptic activity, so small transient, short transient of epileptic activity between seizures. This research has shown that there is accurate localization of epileptic activity. It's concordant with intracranial EEG. It predicts good outcome after surgery. There have been several independent studies, meta-analysis, and automated analysis also to increase and facilitate clinical use. So if you want to go further, instead of just looking at the source with maximum power, you can use an atlas, estimate the source activity in all different regions of the atlas, and then you can look at dependencies between the signal of different regions, different pairs of regions, and you can build then connectivity matrices and look then at connectivity relationship between the activity of cortical sources using graph theory analysis, and look at different network metrics such as outflow, efficiency, clustering, etc. Why is it important to look at connectivity? Well, we know that epilepsy is not only a focal disease when you want to localize a focal pathological activity to perform surgery, but it's actually the result of a network disbalance. And this has been shown by several different types of techniques, from intracranial EEG that was developed about 60 years ago, much before the advent of modern imaging, but also modern studies of function and structure, like here you can see EEG, MEG, simultaneous EEG, fMRI, I'll talk to it a bit more in detail after, and structural imaging with tractography that all show very complex patterns of changes in not only focal abnormalities. And the other reason why it's important to look at connectivity, it's because epilepsy hides. So if you want to look only at the source of epileptic spikes, it's often difficult because there is no spike. And this is because, of course, with the EEG, you only look at the brain with through a very blurred and dirty window, and many of the things that happen at the cortical level are missed by visual detection on the scalp level. So this is an example from simultaneous recordings of scalp EEG with high-density net and intracranial depth electrodes, where you can see that there are spikes in green that you see both at the cortical level and at the scalp level, and spikes in red that you don't see at the surface. So with this connectivity analysis and network imaging, we hope to be able to maybe better localize epileptic activity in the presence of visible pathological activity or in its absence at the beginning of seizures. We would like to detect this epileptic activity to diagnose patients maybe after a first seizure, so be able to have more accurate diagnosis, and maybe to have some information about the prognosis. So what will become, can it be a marker of treatment response with medication or after surgical intervention? Of course, all this gives us the opportunity to assess physiological networks and also their reorganization in a chronic disease. Maybe a chronic disease even with an acute intervention in the form of surgery. So one of the clinical application that we addressed with connectivity, with EEG-based connectivity, is to use the very nice temporal resolution of EEG to look exactly at the connectivity changes at the time point of transient epileptic spikes between seizures. And so we saw that if we look at a network marker of a global efficiency, we found that the patient with a good outcome had a lower global efficiency compared to the bad outcome. So recording before the surgery was, in a way, prognostic at group level of the outcome of the seizure control. So maybe this efficiency indicates us that a larger network efficiency may be an easier propagation of pathological activity, a more widespread network is a bad prognostic sign. Of course, I told you it's not always easy to find spikes. So this was a study that we performed on EEG segments, EEG recordings between spikes, so in the absence of detectable pathological activity for an expert clinician. And in controls, first we found an interesting finding was that the highest outflow was coming from the posterior cingulate cortex, and this was a directed connectivity measure using PDC, so based on the Granger causal modeling. And we found that there was a posterior to anterior projection of information flow in the resting state of healthy controls. So you can see here that with EEG connectivity, you can add some directionality and dynamics over some, for instance, resting state studies that are performed with fMRI. If you look at pathological groups, so patients with epilepsy of the temporal lobe on the left side or on the right side, the left TLE and the right TLE, then you can see that the highest outflow comes from the pathological temporal lobe on the left for the left temporal lobe epilepsy group and the reverse for the right temporal lobe epilepsy group. And with these connectivity patterns, we were able to train a classifier and obtain a very high accuracy for discriminating patients versus control and even patients with left-sided versus right-sided disease. With a different approach and different connectivity measures using weighted PLI, we studied patients with generalized epilepsies, also in recordings without epileptic spikes. And here we found that basically there was a very strong reorganization of the connectivity pattern. So the posterior hubs that were predominant in the control subjects then lost some of their hubness or diminished some of their hubness that was transferred towards frontal regions. And this added some information to the diagnostic accuracy. And this was the study with high-density EEG, but we could show that downsampling the EEG to a regular clinical routine EEG also contained this information and could be helpful as additional diagnostic information. So EEG is not only dynamic and easy to use and easy to apply to patients, even those who are maybe prone to movements, but it's also a technique that can be combined with other modalities, also simultaneously. So I showed you the big workup for patients with epilepsy, but these were kind of separate sessions. Here you can do, as you know, simultaneous EEG fMRI. So simultaneous EEG fMRI is about 30 years ago, and initially it was spike recorded, it was not continuous recording because of the artifact caused by the gradients. But now we have very good safety protocols and correcting algorithm, and we can correct the EEG, identify epileptic spikes or other EEG features of interest, depending on your research. And you can look then at the bold correlates of these specific events. And for epilepsy, we find complex networks of positive and negative bold changes correlated to epileptic activity. The maximum changes are concordant with intracranial EEG and can help predict outcome after surgery, but very often we have no spikes, so low sensitivity, And this complex network also posed the question of specificity of the technique. I'd like to show this study, even if it's a bit old, but this was my first EEG fMRI study, inspired by Christophe Michel, by the time when I did my fellowship in London. And in this study, we used electric source imaging and its temporal resolution to be able to discriminate between hemodynamic Bolt changes related to the onset of epileptic spikes compared to later time point of the epileptic spikes. You can see here that you can add temporal resolution and improve specificity by combining the techniques. What about improving sensitivity? So you know that you can look at the EEG not only in terms of signals for each channel, but in terms of map that change over time. And you can look at the occurrence or the presence or the probability of presence of a pathologic map, here a map related to epileptic activity over time during the EEG recorded in the scanner. And then you can look at the bold correlates of this map on the fMRI data. So we did a study together with Frédéric Grouillet and Christophe Michel, where we looked, basically this is an illustrative example where you can see here that the spike of this patient that was recorded outside of the MRI was used to build a map, and then we look at the presence of this map inside the scanner, and we found that the bold correlates were well concordant with the subsequent surgery that made the patient seizure-free. And with this technique, we were able to have precious individual additional information for the clinical management of patients in about 80% of the cases in those MRIs that were, EEG fMRIs that were otherwise not contributive. So these are co-occurrence of positive and negative Bolt changes, but what if you really want to look at network in terms of connectivity? So here we did a study on patients with network alteration with and without spikes. So this is an illustrative case of a teenager with left frontal lobe epilepsy related to a brain development disorder, tuberous sclerosis. And you can see here that the network, this is the network here involved in the left frontal spike. So you can see that there are left frontal Bolt changes, but also in other lobes and in the other hemisphere. And if you regress out the effect of the spikes of this data set, then you can see that the functional connectivity between these regions is almost the same as the network related to spikes. So it's not only the spikes that drive the link between these regions. So it seems that there is deeper connectivity changes in this chronic disease, and you could see it in a way as a new or modified resting state network in this patient. To go a bit further, we tried to combine and compare connectivity maps obtained from EEG from connectivity map obtained from fMRI. This is the work led by Jonathan Wirzig, where he looked at correlation between fMRI and EEG in different frequency bands, and he found a very reproducible correlation between several independent data sets of 1.5, 3 Tesla, and 7 Tesla. And then he applied this technique on patients, and patients again with temporal lobe epilepsy, and you can see that this correlation of EEG and fMRI, so of neurophysiology and hemodynamic signal, is basically altered in patients with different types of epilepsies. So maybe this is also a tool to better understand diseases and maybe serve as a biomarker. When I was in London, we did very pioneering work that required a lot of safety and data quality preliminary work by David Carmichael, who led that study, because we performed fMRI on patients with intracranial EEG. And this had two very interesting outputs. The first was that if you look at very precise and very focal cortical pathological activity on the EEG, intracranial EEG, then you could look for bold changes also in regions that are not covered by intracranial electrode. It could tell you if there may be secondary epileptic foci that should be considered and that were not sufficiently targeted. And the other interesting aspect is, of course, you can study a basic coupling between electrophysiology and hemodynamics, for instance, here with finger tapping, but also you can look at the resting state. And here, this is a recent study. It's an old data set, but from which there are so many fruits to be eaten that this is a recent paper. We're looking at the correlation between electrophysiology here. You see different frequencies of the EEG and the hemodynamic signal in task or in rest. For the clinical activity, so we can combine some of these multimodal activity simultaneously or in close together sessions. This is a work that we did almost 10 years ago now, together with other CIBM members, so Frédéric Grouillet, Valentina Garibotto. So we combined for a single session for the pre-surgical recording the structural MRI, the EEG fMRI, from which we drew fMRI maps and electrical source imaging, and the PET, because it was a simultaneous combined PET and MRI scanner that was at the time installed at the University Hospital of Geneva. We also did some EEG fMRI work at 7 Tesla, again, so spanning 10 years, different scanners. We started at the EPFL on the 7 Tesla of the EPFL, then there was some study in Bern, and now we are back in Geneva on the new 7 Tesla scanner, but Frédéric Grouillet here, who led that study, found very focal bold changes correlated to epileptic spikes. Now we are hoping to translate this work, maybe taking inspiration from work that was also presented by Peter Bandettini of layer-specific fMRI, how much we can take advantage from it in single subjects and in EEG, with an EEG fMRI setup is still work in progress. We have work that was also initially initiated by Christophe Michel of recording multi-channel EEG in rodent models of epilepsy, here in mice, where they have intrahippocampal injection of kainate to mimic, to model temporal lobe epilepsy. And Isotta Rigoni showed very nicely, together with the group of Charles Queriot, that there were some important contralateral changes in connectivity that were developing over time in this mouse model, in which you have the benefit that you can look also at the period between the initial insult, the latent phase, and then the chronic phase of the disease. Some more work in progress, because we're always enthusiastic to continue and explore new frontiers, relate to the combination of structure and function. And for that, we have collaborated with the group of Dimitri Van de Ville and Giulia Preti to look at apply graph signal processing on the EEG. So the principle is so that you record diffusion MRI and can build the tractography and the structural connectome, and then you decompose the eigenmodes, so the network harmonics of the structural connectome. And on the other hand, you look at the activity of the region, cortical regions estimated by source imaging from the high-density EEG. And if you combine those, you project the EEG time series, so the region of interest time series on the network harmonics, and you look at the proportion of the low frequency versus high frequency harmonics, and we were able to show here that, again, with a dynamic analysis during epileptic spikes, at the time of epileptic spikes, there is a higher proportion of the signal that is a functional signal that is coupled to the structural connectome compared to before the spikes. could compute structural decoupling indices in different brain regions to find regions in which this coupling is more important, and this was here in the mesial temporal lobe of this patient with temporal epilepsy. And we are now currently exploring how this information can inform, again, prognostic features of good and bad outcome. And you can see here that in patients with good outcome, there's a significant difference compared to a bad outcome with a higher structural decoupling, structural coupling. Of course, this was done on a template structural connectome, but we know from several studies, including one that we did, again, 10 years ago, time flies, with the group of Jean-Philippe Tirant, that there are structural changes and connectivity changes that are multifocal and widespread in temporal lobe epilepsy and other forms of epilepsy. There is a redistribution of the hubs, and so now we are looking towards studying structure function on structural connectomes that are more representative of pathological conditions. I want to show also some work of, I want to show also some work from the CIBM staff that joined my research group. This is work by the team of Thomas Ross. I've cited a lot of collaborators. I haven't shown any pictures so far because I thought otherwise it's really the family album. So, but the only people that you will see the pictures are the ones from the CIBM staff. So Thomas Ross here, who is involved in some projects about EEG normative projects to be able to have database to which we can compare EEG of specific persons and maybe do some clustering analysis to identify pathological activities and pathological conditions. Thomas Ross is also working towards using EEG not only as a diagnostic tool but also as a therapeutic tool with protocols of EEG neurofeedback, for the moment applied to psychiatric population, but other applications are envisioned. And of course, to do all that, to integrate these EEG tools into individualized precision medicine, we need good software. So Denis Brunet has developed the CARTOOL software with the funding of the CIBM and the group of Christophe Michel for over 20 years. This is an EEG tool that allows you a fast review of EEG, all kinds of complex analysis, also integration with MRI head models, source imaging, intracranial electrodes, and we will be working towards adapting it and making it compatible with other tools such as the connectome mapper developed at the CHUV and the Chanois initiative that has been adopted by the CIBM for data for managing the database. I want to tell you a couple of words about the work that Nicolas Reury is doing on a simultaneous scalp and intracranial EEG. So we have about 9 patients in Geneva that have had this recording at the end of their clinical intracranial EEG. In those patients, we were wondering if the very focal spikes that are not visible at the surface and that are limited to the hippocampus, what kind of effect they have on the scalp EEG. So you have epochs with intracranial spikes, nothing on the scalp EEG, and you have epochs without intracranial scalp, nothing pathological on the scalp EEG. And the result is that there are significant changes in different frequency bands of integration and segregation as measured by efficiency and clustering coefficient. And that you can look at this at the global level, or you can look at it at the regional level. And you can see here, and for the different frequency bands, different distributions of these changes, so these very focal spikes that look silent on the scalp are actually very loud and do very strong changes of the connectivity patterns. Nicolas and his team hosted in my lab for his Ambition project are now looking at time series, so not only spikes, but continuous EEG and how scalp EEG can reconstruct the activity of intracranial electrodes, so looking at virtual electrode. And you can see here an example of the intracranial EEG and the reconstructed intracranial EEG, where you can see that there's a good reconstruction for physiological and pathological patterns, so physiological and pathological patterns. Probably the reconstruction is a bit less good for the ongoing activity, and so we are looking at the accuracy of source imaging in these different data. And so this is collaboration with Pigorini in Milano. You can move even further with the EEG by looking at microelectrode, looking at multi-unit or single-unit activities. There are different tools that are used in clinical research. One is the Utah array for cortical recording. Another one are microelectrodes mounted on clinical depth electrode, either at the tip or along the shaft. These are here tetrodes. And you can then hope to find correlates between single unit activity, as you can see here, the burst and silence of single neurons correlated with the intracortical and the scalp correlates. As a take-home message, the sentences are very simple, so I hope I was able to convince you that EEG offers multifaceted spatial and temporal analysis of brain activity with multimodal and multi-scale combination. Epilepsy surgery and research offer invasive validation for EEG and other imaging techniques that can also give insights into normal brain function, and that new approaches may offer network-based diagnostics, prognostics, and therapeutic targets. This is here a figure of a very nice paper that was published in Brain 2 years ago, where they show and discuss how network imaging could be used to target resective surgery, as you can see here, or neuromodulation, as you can see here. And this is the work, of course, of a very large network. I'm sure I forgot many people. Please apologize. And so my special thanks, of course, as I said, go to Christophe Michel, who was the former head of the EEG section, to Reto Meuly, who was my MD director 5 years before the CIBM was even founded, and who introduced me to the field of imaging. Thank you very much.